Hi, everybody. This afternoon, I'm going to be talking to you about the respiratory system. So you will have slides to refer to. You'll have my lecture from class, but I'm also going to do a quick little review here in case for some reason you need to refresh your memory or you're unable to make it to the lecture. So the respiratory system is, of course, one of the most important systems in the body. If we're not breathing, nothing's going to happen, right? No oxygen going to our cells, we die. So it contains the lungs and the air passages. Okay, this system is responsible for taking in oxygen, and also it's to get rid of carbon dioxide. We only have a 4 to 6 minute supply of oxygen in our body. And that's why, I mean, when you really think about it, CPR, those that we can bring back are very, very fortunate. And those are usually the ones that we can get to rather quickly when we see them not breathing and their heart is stopped. So there's a very limited amount of time where we will actually have successful CPR when you consider that's only a 4 to 6 minute supply of oxygen to our cells. And, you know, once the brain cells aren't getting that oxygen, it's very difficult to bring someone back. And if we do, they may not be brought back to the capacity that we know that them in prior to that. So the parts of the respiratory system are the nose, pharynx, larynx, trachea, bronchi, alveoli, and lungs. And in some respects, we have to also consider the blood because that's where this gas exchange is going to take place. So if we start out, we start at the nose, and as you all know, the two nostrils are otherwise known in medical terminology as nares. Okay, that's the entryway where the air eventually comes into the respiratory system. And here we have this area here, which is some soft cartilage, and that is known as your nasal septum, okay? And it's cartilage, so it's not bone. It's still a little flexible, and that's why if you get, like, say, with a softball, it can actually, you know, break and fracture. And this nasal septum divides us into two hollow spaces called nasal cavities. So cavity, as we know, is a simple term for just a hollow space. And within those cavities, we have mucus lining that is lined with a lot of blood vessels. There's mucus in there, and there's a rich blood supply, As the air enters into the cavities, it is warmed and filtered and moistened by the mucus, which, you know, that's one of my first things that I don't like is mucus. As far as feet and mucus, that's my issues with when you're talking about taking care of people. So the mucus is produced by these membranes that line the inside of our respiratory tract, and it helps to moisten the air, and it also helps to trap pathogens and dirt. Okay? How the air is actually filtered down and so forth is these tiny hair-like structures called cilia, very, very fine hair-like structures that kind of move things down into the respiratory system. And they trap dust and other particles. Also, what else can I tell you about this? All right, within that area, we also have our sense of smell, right? And that from the olfactory receptors that are inside of our nose. So when we think olfactory, that is the stimulate the olfactory nerve in our brain. And that's when we get these receptors pick up our sense of smell and send those signals to our brain. And our sense of smell is actually the most sensitive sense that we have. So you can see in the slides that I put a little video about smells and how we are different from, say, dogs and things like that as far as our sense of smell. But they say that it's very, very sensitive to us. And I have read many times that they think that the sense of smell is the last sense that we lose as we die. Don't ask me how I know that, but we also have the nasolacrimal glands. So lacrimal means tears, if you remember from your medical terminology last year. And these ducts drain into the sinuses from the eye, and it helps to provide additional moisture to the air that is being brought in. So these sinus cavities, okay, are in the skull, and they are surrounding this whole nasal area. They're lined with the mucous membrane, as I said, which also warms and moistens the air. So all along the track, we're going to have mucus that warms and moistens and kind of lubricates the air to go down. Interestingly enough, though, these hollow spaces here are what provides us with our voice's resonance. So the resonance means, I don't know if you've ever heard that before, but that's like how our voice actually sounds to other people. So as we all know, if we have a sinus infection or if we have a cold and these sinuses are kind of full, it affects our sound of our voice, right? So resonance is directly related to how, I will say, empty or full our sinus cavities are. So down from the sinuses, we go down to the pharynx, okay? And the pharynx is another term for the throat. It lies directly behind the nasal cavity. As air leaves the nose, it enters the pharynx. It's divided into three sections, okay? We have the nasopharynx, which contains the tonsils or adenoids, which are lymphatic tissues that kind of sit in there. We also have in this upper area of the pharynx is also containing your eustachian tube, which is the tube that leads from your ear down to the pharynx. We have the oropharynx. So oro is the middle section, and that's in that oral cavity. Makes sense, right? And then we have the lower section, which is the laryngeal pharynx, which is lower going towards the larynx, which is the next part of the respiratory tract that the air goes down. Now, when we talk about the larynx, another term for that is the voice box. And it lies between the pharynx and the trachea, okay? And here we have a series of C-like cartilages that are kind of following down. And we have one, if you're a man, you have one that's more pronounced, a male, and that's called your Adam's apple. I don't know if you've ever heard of that before. So sometimes you can see it more pronounced from other certain males than others. And it's in that area where the larynx has two folds that are called your vocal cords, okay? And the opening between the vocal cords is called the glottis. And as air leaves the lungs, the vocal cords vibrate and produce the sound that we hear from our voice. And that sound is directly affected by those sinus cavities with the resonance, that the actual like quality, we'll say, of the sound of your voice. With that in mind, we speak with all of that going on in our tongue and our lips, because the tongue is what gives us the clarity or the crispness of our speech, right? So when someone has a stroke and they're talking and their tongue has been paralyzed on one side or another, and they can't really talk clearly anymore, right? All right, I hope that gave you a laugh. So then we have the epiglottis, which kind of sits over the opening of the larynx, and it's a little piece of leaf-like cartilage that sits over that, and that helps to prevent the food that's going down in that same area, because you have to remember we have the esophagus and this trachea, and the trachea has the air going in it, but we don't want anything else going into it. We don't want any food or particles or anything like that. So the epiglottis kind of sits over the trachea to prevent the food from going in there, the larynx and the trachea, okay? Trachea is next. It's the windpipe. Also has a series of C-like cartilages going down. As we all know, the trachea over here, we can put a hole in it and create a tracheostomy. So ostomy is a hole, and that's where they put the trach tube in. And if someone's on a respirator or not, they don't have to necessarily be on a respirator. That tube kind of comes out here. That's the place where they can put medications into. You can have your inhalers on there. You can put, in an emergency, you can put actual medications that we use in CPR. And also, what's the other thing I wanted to say about, losing my train of thought. With the trachea, you can have it attached to the respirator or not. And then also, you don't want to get any water in it. However, you can take the suction catheter that you would want to do, because sometimes mucus can accumulate in there. And you can go directly into, it's a sterile procedure, go directly down into the trachea, down into the bronchiole, and suction out with a suction catheter. Not my favorite thing to do, okay? And you kind of get that slurping sound. But if somebody has a blockage or, a mucus plug, they call it, you need to get that out. Otherwise, they can't breathe. So from the trachea, we start to go down, and then we're going to have two branches out, as you can see in the slides, and those are called bronchi. All right, if we've heard of bronchitis, that's where it's directly related, inflammation of that bronchial area. And they are near the center of the chest. And each bronchus or bronchi carries the oxygen down directly into our lungs, okay? They get smaller and smaller. So it's a tube, and it just gradually gets smaller and smaller. It has little pieces that come off of it and offshoot. It's almost like a tree. They call it the bronchial tree. And eventually it gets down to these little tiny bronchioles. And at the ends of these bronchioles, we have the alveoli. And the alveoli are almost look like grapes, they say. We have about 500 million of these little teeny microscopic alveoli at the end of the bronchial tree. And they have something that is covering these grape-like tiny minuscule things called surfactant. And that helps to prevent these little grape-like things from collapsing. And that's when, like if you see a premature baby, doctors really like them to get to a certain point of age when they are gestational inside the mother, because if they don't get to that certain amount of weeks, which I believe is 28 weeks, their lungs don't really have the surfactant that they need to be able to have a good, better or improved respiratory status. So sometimes those patients need to be on the respirator longer than they would if they had been birthed later in the gestation. So babies who come out at 40 weeks, no problem. The surfactant is there. Their respiratory tract is working fine. And the surfactant is keeping those alveoli nice and fresh and whole. But if we don't have that surfactant, they kind of collapse. And then we can't have the area of gas exchange that we need to breathe. So the divisions of the bronchi are found in the lungs. We have two sets of lungs. So we have the left lung and the right lung. The right lung has 3 sections. The left lung only has 2 sections. And the left lung is smaller because it is on the side of the heart. So Mother Nature took that into consideration. That is a tiny bit smaller than the other one. When you listen to the lungs, it can give you a lot of information about what's going on with your patient. So if you hear something like little tiny bubbles crackling, that could mean that they have mucus or fluid in their lungs. If you hear something like when you're listening to their lungs, sometimes you can hear it audibly without the stethoscope. You might, you would say, oh, what is going on with this patient? Are they having an asthma attack? Are they having an anaphylactic reaction? And they're having their bronchioles are tightening up and the air exchange is not going through. That's what's causing that wheezing sound. Or we can have something called stridor, which is like that, all right, which is, again, not good. So the lungs can provide with a lot of information of if someone's improving their status as far as if they have pneumonia or not. We check the lung sounds, and they're very, very important. Each lung is surrounded by a sac called pleura, and it has a tiny bit of fluid that helps to allow for the lungs to expand and go back to their original size. And what happens is sometimes if you have an infection or cancer, the fluid can get increased around the lungs. And just like as you can have that in your pericardium, which is that sac that surrounds the heart, the same thing with this, the pleura can actually get the fluid that becomes greater than it should be, and the lungs can't expand because they're tightening up around these balloons. So sometimes we have to have something called a thoracentesis. And if you recall from your medical terminology, centesis means to inject a needle and draw out fluid. So that's a procedure that can be done at the bedside. And I've assisted with that many times. The patient feels a lot better after that is done. All right, so the process of breathing, I'm not really going to go into that. It's pretty straightforward as far as the book. We have ventilation is another term for breathing, and then we have inspiration and expiration. Inspiration is taking in the air, expiration is taking it out. And the total package, as we know, if we count inspiration and expiration, is called a respiration. So I think you can just read that chapter in the book. Should be all set on that. The stages of respiration as well. We have external respiration, which is the exchange of oxygen and carbon dioxide between the lungs and the bloodstream. So again, if we recall back and we go to that alveolar section at the ends of the bronchioles, there are many, many capillaries that meet those alveoli. And the oxygen that's carrying the blood that's being carried kind of transfers the oxygen back and forth in this area, and the CO2. So the CO2 comes out of the bloodstream, it goes into the lungs, we expire it out. And the oxygen that we take in gets transferred into the bloodstream, and then that ends up being pumped back to the heart, and the heart pumps that oxygen throughout the body. Internal respiration is that what I just talked about. All right. So the external is the exchange of oxygen and carbon dioxide between the lungs and the bloodstream. And then internal respiration is the exchange of carbon dioxide and oxygen between the tissue cells and the bloodstream. So once everything is, we haven't really gotten too much into the cellular process, but we've just done basic physiology with that. But the cells are, constantly producing these different chemicals that are going back and forth, and oxygen, carbon dioxide are one of those things that are transferring back and forth. So I'm not going to get into that too much. All right, so now we talk about some of the diseases. So we've all heard of asthma. Some of you may have it, actually. And it can be brought on by a number of things. It could be brought on by allergies. It could be brought on by stress, a panic attack, certain medications. And again, those bronchioles get irritated, so they line, the mucus that's lining it kind of increases, and that can help to prevent oxygen from going down into that area. And then we can also have spasms, so the bronchioles actually tighten up and the air can't go through. As we know, we can give people inhalers, oxygen, anti-inflammatories. Asthma attacks, depending on how severe they are, can become emergent situations. Bronchitis is the inflammation of the bronchi and the bronchial tubes. It can be very, very painful, short of breath, cough, bubbly or noisy breathing. You can hear it when you're listening to the lungs. They could be treated with antibiotics, cough syrup, Obviously, bronchitis can also be brought on by continued smoking and chemical exposure. So you can have acute bronchitis, which is something that can be taken care of with antibiotics. And then you can have chronic bronchitis, which is something that's long-term. You just kind of have to live with it. They do medical management with it to try to help you with the problems and symptoms that go along with it. But you're going to have it for the rest of your life if you have chronic bronchitis. Then we have something called COPD, which you've heard of before, chronic obstructive pulmonary disease. That's used to describe any chronic lung disease that results in the obstruction of the airways. Smoking is the primary cause of COPD. The prognosis is usually very poor with those patients. I used to have patients repeatedly coming in with problems with COPD. We'd see them over and over. It's very sad to see someone suffering from that because they have a lot of respiratory distress. You try to help them as much as possible, but it gets very frustrating for the patient. They are very fearful and anxious, and we have to give them a lot of emotional support. Then we have epistaxis, which is another term for nosebleed. And in the slideshow, it shows you a little video of how we can take care of nosebleeds, and you're going to learn that in our first aid sessions as well. Emphysema is a non-infectious chronic respiratory disease. And what happens is the walls of the alveoli that we talked about kind of deteriorate and lose their elasticity, so there is poor oxygen exchange. We have influenza. I'm not going to get into that. That's pretty straightforward. We know about that. Laryngitis is simply the inflammation of the laryngeal area. So if you have that hoarseness in your throat because you're so irritated. Lung cancer is pretty self-explanatory. I think you can read that in the book as well. Main cause is carcinogens or smoke. All right, so better avoid that. It's the leading cause of death in the United States in both men and women. We have something called rhinitis. So that's just an inflammation of the nasal membranes. You might have a runny nose, which is very, very similar to the upper respiratory infection that you'll also see in this chapter. As far as I'm concerned, it's really the same thing. The infection, upper respiratory infection, is being caused by either a virus or a bacteria, whereas a rhinitis doesn't necessarily have to be caused by one of those things. It could be simply allergies that's making you have that runny nose. Sinusitis is inflammation of the sinuses. I think that's pretty self-explanatory. We have something called pleurisy, which is that inflammation of those sacs surrounding the lungs. It can be caused by a number of different things. And as I said, you can treat them with antibiotics, but also they probably would want to do a thoracentesis to remove some of the fluid around that person's lungs because it's very, very painful. And what they'll do is analyze that fluid to see if there is an infection, or a lot of times it's a sign that you have cancer. Pneumonia, I think all of you have heard of pneumonia, begins with a P. That's when we have an infection, but it causes fluid to come into the lungs. So again, you have that shortness of breath. They have to be treated with antibiotics, fluids, and oxygen therapy sometimes if it's very severe. The last two things I want to talk about is tuberculosis. So we've talked about TB before. That's what we have to actually have our tests for before we go into the take care of the patients. It can lie dormant inside of you if you have been exposed to it. So that's why we have to have those tests to make sure that we do not have any TB inside of us. And dormant means it can be asleep, and then all of a sudden it can just come out. It's highly contagious, so you don't want to get any of that. And in the olden days, TB used to be very rampant, and people used to be dying from it all the time, but thankfully that was taken under control. And lastly, we have sleep apnea. Apnea, as we all know, is the lack of respirations. So what happens is the person is sleeping, and then they have periods where they're not breathing, and then their breathing returns, and it may be a little rapid, and then it stops again. People who are obese, if they snore a lot and they might have obstructions causing the snoring, those are the people who are more likely, smokers are more likely to have sleep apnea. And then we can have them be put on a CPAP machine, which is explained in your book, but basically it's giving pressure to keep those passageways that are obstructed while you're laying down and sleeping. It keeps them open, and it helps to have a more continuous respiratory cycle. So I know I went fast. I hope it helped you to review the respiratory system. Again, look at the slides. I feel they're very, very helpful for you. Come to class, as I know you guys do. And that's my explanation of the respiratory system. Bye-bye.